It's going to be just us. We'll go ahead and get started. Thank you all for being here today. This is a presentation about the Medical Scribe program at SVSU. I'm John Lowry, for those of you who don't know me. This is a program that we put together. It's trained a lot of students to do some pretty cool things, and it works really well. Any questions?
Tell us more.
Okay, I'll tell you just a little bit more. So to start off with, really this is an example of experiential learning, workplace learning, specifically in healthcare. And this is a rare opportunity, something that not every undergraduate student gets to do. The quote that I just want to start off with is from John Dewey, who's one of the pioneers and one of the best written people on experiential learning. It says, "We don't learn from experience, we learn from reflecting on experience." And really that's true. We don't learn just because we did something. We learn as we go, oh, I did this. Oh, I didn't do it right. Oh, I figured it out. Oh, how did I do it? Okay, now I can do this again over and over again. It's that reflection and that application that really begins the learning process. So the issue, as I mentioned, very few undergraduate students who are preparing for a career in medicine and many other, especially graduate level health professions, get a chance to have any experience within that profession before they commit to it. So how do we provide experiences upon which students can reflect and so they can learn? That's really what this program is all about. Providing some experiences for the future. Both for the here and now and for the future, I should say. So Medical Scribe. I know a lot of you know me and know a little bit about this program. But before this, you probably never heard of a medical scribe before. A medical scribe is a professional who takes notes and assists in the documentation process as a physician is interacting with patients. They help develop the official medical record of the patient encounter, which captures the history questions that are asked, and it captures the physical exam, and it captures whatever procedures and things are done as they interact with the physician. So in order to do this, they obviously have to know what's being said. They have to understand medical terminology. They have to have a working knowledge of knowing what medications are, how to pronounce them, or at least how to recognize them when they're spoken or written, to understand some basic medical type of stuff. They also have to be able to use electronic medical records, which is really becoming almost universal throughout all of healthcare, but especially in large hospitals. Electronic medical records really came on board almost a decade ago and are fairly standard, especially in larger facilities. They also have to understand a little bit how healthcare is delivered, the process of being seen by the physician. Well, you go through triage and you meet with nurses and other people, and you might get asked the same questions multiple times before you see the physician, who will ask you the same questions, but there's a process to that. And then what happens when I order a test, and then how long, why am I here for 3 hours if I'm trying to get in and out? So understanding how that all works to understand the context for working in the field. So a couple years ago, Dr. Deibel and I came up with the idea for a training course that would train interested students, typically pre-med students, to be able to work as medical scribes. And so we put a lot of time and effort into developing this course. We were thinking, what should we have them do? And even that was kind of a little bit of a struggle. Weren't sure exactly what they were going to do, other than being there and kind of entering things in real time on the computer. But we weren't sure exactly how they were going to do it, and a lot of other stuff. So we've come up with what it is today, which is a university course, Kinesiology 380. It's a university course, which is good because it helps them pay for the class through scholarships, financial aid, things like that. If they were to go off and find a place to do some other training, like phlebotomist training, CNA, they would have to pay out of pocket for that. But here they can get it covered by financial aid. It's also on their transcripts, so wherever they go, that course is going to be with them wherever they are. They need to have a few science courses as prerequisites, not because we're necessarily talking a lot about chemistry and biology, but just so that it's not a brand new freshman going, oh, I'm going to be a doctor, and I'm going to change the world. And it's like, okay, get a few classes under your belt, and then once you kind of find yourself, we'll take you in. So that's the course. I'll talk to you more in depth about what the course is. After they have completed the course, these students are eligible for employment. I say eligible because it's not a guarantee. We're not going to make you work if you don't want to. And also, not everyone who completes the course has the skills in order to really be an effective scribe. So they're eligible for employment, but there's no guarantee. However, the demand is high. So our physician facilitators, which is what Covenant calls them, work in the emergency department as well as the neonatal ICU. And there's also, I get calls from other doctors' offices, surgeons when they're in the clinic, not in the OR, podiatrists, people who aren't even physicians, physical therapists, other healthcare providers are going, hey, I'd like someone to, they're curious about it. They've heard about it and they want to know, is this something that we could look into? Their duties center on documentation. That's really what they're there to do, but they can do a lot of other things too. Anything that helps speed the delivery of healthcare. Doctors in a room with someone, oh, could you go get this tool, or could you go follow up with this person, go ask a question, or do something that's going to facilitate patient care. These scribes, physician facilitators, are able to do that. Even if it's something as simple as, could you get a cold turkey sandwich for a patient, which they really love, right? They do not provide any clinical patient care. Make that very clear. They're not putting their hands on patients. They're not. It's kind of funny, they have to be CPR certified, but in that environment, in the ER, they're probably the last people who would ever actually give CPR to a patient. That's what the attendings and residents and nurses and just about everybody else is there to do. So, instead of telling you how it works, I've invited one of our students, Stephanie Coates, to come and do a little demonstration for you. So Stephanie, come on up. Stephanie has been a scribe now for a couple of years. Stephanie is currently one of the lead scribes, which means she does a lot of cool stuff. You want to tell them about what you do? Actually, go ahead and tell them what you do first.
As a lead? Or just in general?
Yeah, as a lead scribe.
So as a lead scribe, there's 3 of us right now who are actually leads. My other 2 partners are actually in class right now, so they couldn't join us. So as a lead, that kind of means we look over the other 20 to 22 scribes, however many we're carrying at that time. We do things such as scheduling and evaluations, checking up, making sure they're doing the appropriate documentation, that we're not making critical mistakes or making false records, I guess you could say. Another big part is that we do help with the scribe class. The 3 of us actually attend the scribe class each week and help teach it. We kind of go through these videos each week in the scribe class and practice notes so that we can get those students ready to interview for the position if they're interested in it, and we can get really good scribes working with our doctors. Kind of like John said, our biggest aspect of work is making sure that we're doing things most efficiently for the physicians, making their jobs easier so that they don't have to stay 2 hours after their shifts finishing all their notes, things like that. They really appreciate that. Another thing, kind of the administrative aspect, is we also meet with our 2 physicians, Dr. Deibel and then Dr. Smith, and kind of go over administrative things. If there's anything that the doctors need to relate to us or that we need to relate to the doctors from our end, if something needs to be documented differently, if we have any new procedures that we're getting special notes for and things like that. And that way when we have our scribe monthly meetings, we can go there and kind of give them all the new information that we got and passed along so everything's still being documented correctly.
Okay, so I've got one of the things that we've developed over the years is through the Covenant Simulation Lab. They've developed a number of videos that are simulated patient encounters, and they're pretty close to the real thing, and these are what we use in class to help students learn how to be a medical scribe. So she's going to show you. So how many of you were here for Dr. Coppola's speech about doing authentic, real stuff? This is, I think, exactly hits to that. Okay, so go ahead. Whenever you're ready, just hit play and then go back to this one here.
Yep.
You'll hear it. You don't need to see it all that well.
I'm Dr. Christensen. This is Alyssa. She's a helper here doing some note taking for me. What's your name?
Beth.
Beth, what's going on?
My nose is bleeding. I was watching TV this morning and eating my breakfast and it started and it just hadn't stopped.
Okay, and so how long ago was that? How many hours would you guess?
Well, I was watching the news and then I did some gardening and I came in and had lunch.
Probably 4 or 5 hours?
That was probably 5 hours.
Okay, and has it been bleeding a lot?
Yeah, it started off slow and it just keeps getting worse.
It does?
Yeah.
Okay. Do you take any medicines that would cause you to bleed more?
I'm only on a few medicines. I take one for my AFib. It starts with a C.
Coumadin?
Yeah, that one.
Okay. Do you take anything like aspirin or Plavix or anything else?
No, nothing else.
Okay. All right. And besides the bleeding, you didn't fall or hit your head or anything like that caused this?
No,
It just kind of started?
Just started when I was watching TV.
Sure. Have you been lightheaded or dizzy from it?
I don't think so.
No?
No, I've just been sitting down a lot today.
All right. Have you had an upset stomach or been throwing up from this?
Maybe a little bit of an upset stomach, but I can kind of feel it in my throat.
You feel it running down your throat?
Yeah.
Okay. Haven't thrown up though?
No.
Okay, so nauseated without vomiting. Any shortness of breath or chest pain?
No, I'm okay.
Haven't been coughing anything out?
No.
Okay. Any fevers or chills or anything unusual? No. Okay. And so you said you have atrial fibrillation, other medical problems that you know of?
No, I don't think so.
Nothing else?
No.
Just the Coumadin?
Yep, just that one.
Okay. Any surgeries in the past?
No, I don't think so.
Okay. All right. And so I'm just going to listen to you breathe here, listen to the stomach, make sure everything's going okay there, and then we'll look at the nose, okay? Any questions so far?
No.
No? How about you, Melissa?
No.
All right. Deep breath for me. Breath out too quick. Just going to listen to the heart here. So it's irregular, but it's at a normal rate of about 85. Go ahead and lie back for me. Any that's hurting?
No.
You just been a little nauseated, no pain down here now. Okay. All right, well, I'm going to grab some Afrin here, okay? So when we take a look at the nose, what I want you to do is go ahead and lean forward. All right, and then I just want you to actually blow your nose.
Okay.
Okay? So blow all that cloud out of there for me. Good. Go ahead and lie back now. So, and it's been pretty much the right side?
Yeah.
All right, so I'm just peeking in both sides here. The left looks clean and dry and normal tissue, no obvious source of bleeding. And on the right, looks like anteriorly there's a little spot that's been bleeding. It's continuing to ooze. So what I'm going to do is squeeze some of this Afrin in that side. Okay, these are 2 big squeezes. I just want you to kind of inhale when we do that, okay? So, big squeeze, and then another one right now. Okay? So what I want you to do now is we'll get you a clean towel. Here's a clean towel. Just go ahead and apply some pressure. And I'm going to put a clip on. Okay? So we'll put this clip on. And then you can just use your towel to kind of blot if it's dripping out. Okay? So you can go ahead and just lean forward, let us know if there's a lot that's going down your throat still, but usually this pressure kind of helps slow things down with the medicine. Alright? In the meantime, I'm going to have to check your blood work to see where your Coumadin level is, your INR. So we'll check an INR. We'll check a CBC to make sure she's not anemic from bleeding today. And we'll go from there. Any questions? No? And if this doesn't work, when we get your labs back, we'll come back, check it. If it's still bleeding, we may have to put a nasal pack in.
Okay.
Okay?
Yep.
Any questions? No? All right. We'll be back.
So there's 2 labs that were ordered, and these are the...
All right. How are we doing? Still dripping?
I still think so, and I can still feel it in my throat.
Okay. All right. So your Coumadin level is actually just a little bit low, so I'm not concerned about having to fix that today. You will need to follow up with your doctor in a few days. They may need to check it again and adjust your medicines. In the meantime, what I'm going to get set up to do here is pack your nose. Okay, what that involves is it's called a rhino rocket or a nasal tampon. And I'll soak that, we'll push it back into that side and fill it with some air so that it kind of applies pressure on the area that's bleeding. Okay, that stays in for about 3 days. So you need to call your doctor after you get done today, get an appointment set up in 3 days, and then they take it out. Okay, in the meantime, you're going to go home with an antibiotic. Okay, augment. Actually, we'll do Keflex today. And once they get that pulled out, then you can probably stop it. Okay, that just prevents infection and sinuses is all it's for.
Okay.
Any questions?
Thanks.
So we'll put that in. We'll keep an eye on you. Once things kind of slow down, then we'll get you going home. Okay?
Okay.
Any questions?
What was the IR?
IR is 1.8. So it's almost right where it needs to be, and I'm not going to change anything about it today. Okay? Anything else? All right.
Okay. So did anyone hear anything that they weren't sure what it was? Maybe what an INR is. You saw her write all these SOB, CP, ASA, AFib, all these various things there. So what she's going to do now is she's going to take this information and she's going to develop that into a nice flowing paragraph called the History of the Present Illness, or HPI. This is a standard way that they chart all those millions of questions that you get asked first thing when you go see the doctor. And there is a rhyme and a reason to it. It's supposed to flow very well, and there's a kind of some patterns that you can use to make sure you get the right information in there. After she gets this HPI stuff done, why don't you go, do you want to quickly jump down to a review of systems or physical exam? Mm-hmm. So she'll take that and get it through there. This part here, the review of systems, is kind of usually after the physicians ask the important questions, they'll go through and just make sure there's nothing else that they may be complaining of. So they may ask a few questions, or they may ask, is there anything else that's bothering you today? So that's their chance to incorporate, whatever else they may be complaining of, or to rule out some of the things that they're going to make sure that they're not having. So there was no fever, no chills. She obviously did have a nosebleed, no shortness of breath, no chest pain. Those are questions that she was asked. So this is another part of the chart. Fortunately with this, we have a lot of check boxes that can be checked. And what happens is as those get checked, they will populate into the medical record. Here she's writing a note about, yes, she bruises or bleeds easily, but it's because she's on Coumadin. So she puts a note to that effect. Okay, so go ahead and go show them what that looks like in there in the note then. So all those check boxes you just put there, red things show up, those are bad. And it just populates that for them in the note. And then physical exam, this is where the physician starts to listen to the heart, lungs, do an exam, in this case of her nose. And typically what scribes do is they'll actually have a macro, which is a kind of a pre-programmed exam that they can use. Depending on which physician they work with and depending on what they normally do, they can load at least the template of a regular exam and then just go back and change whatever things aren't normal. So in this case, a lot of these things she's fine in almost every way that we care about. The difference would be under HENT. We'd go up there and go ahead and click on that one.
This mouse pad is not good.
I know, it's a terrible, it's a terrible thing.
It's really bad.
Under nose, if she had like a external wound to her nose, you could maybe draw something in there, although now they take pictures and upload those into the chart. Or you could just make a comment to say kind of what he said there, which was there was a little spot in the right anterior nair, and the left one was clean, dry, normal tissue, that kind of stuff. So this is what actually happens. This is what we teach students to do in this class. We give them a lot of practice. We teach them obviously a lot of terms and the things that they need to be able to type in there. But this is essentially kind of the drill that they do. So this would be something that they can do, a lot of this in real time, as the physician's in there with the patient. Sometimes, depending on the complexity and the length of the case, they may go back to a computer workstation and work on it in between, or as they go around from patient to patient, maybe have some time to enter some more notes there. And then the last part would be the ED course, which is everything that happens after the exam. So in that case, the doctor had her blow her nose, they gave her some Afrin to see if that would help it. They put a clamp on the nose, and they left the room, they came back, that was still bleeding, so they were going to put what's called a rhino rocket, which is a big thing in the nose to help stop the bleeding, to help it clot up, which she would then have to leave in there for a few days, follow up with her primary care physician in 3 days. All of that would go into this section here called the ED course. So that's what Scribes do. Thank you very much, Stephanie.
No problem.
Magnificent. In all fairness, we did just watch this video in class yesterday, but I don't think it would have made any difference if we hadn't. Stephanie would have. This is a pretty easy case considering some of the ones that they end up seeing there.
John, I couldn't see. Did the Scribe have like a tablet? Is that what it?
In the video, the Scribe was just taking notes on paper.
That's what I can tell.
Yeah, in the video, and that was one of our actual Scribes who's now finishing PA school. She just had a note of a hard piece of paper, and she was taking notes on there. Most of the time, they'll wheel in have a laptop, or depending on the case, if it's a trauma and there's lots of people in the room, you'll be back there with a piece of paper, because there's 25 other people in the room, and they may be stuck there for a couple hours at a time.
When did you take the course?
It's been 2 years now?
Sophomore year.
3 years?
So, almost 3 years ago.
Okay, so 3 years ago when you walked into this course, how much knowledge did you have of this?
Of epic or of medical terminology?
I'm just talking about what do you, terminology, when you walked in, how did you feel about that course? What was your basic line knowledge?
I felt okay about it. I kind of come from a medical family. My mom and sister are both nurses, so I would always listen to them talk about things. But after taking the course, I still don't feel like I know so much more now just working and learning things while I'm there than I would say like the medical terminology and stuff like that. Because there's still so many different things that I hear. I'm like, oh, what's that? I've never heard of that before. So I think that the actual experience at the hospital is so beneficial in learning things like that. The class is obviously very helpful and gets you to that point where you need to be, but then once you get there, there's still so much more learning that you get to do.
So could you see yourself as a sophomore being a leader and doing all the stuff that you're doing now? I mean, is that
Yeah.
I guess encompass the experience.
Right.
For me.
So I took the class as a sophomore, and I got a job right away, and I was so excited about it. And about, I think it was like 10 months after I started, they were offering a new lead position because one of our other leads was getting ready to go to graduate school. So I'm like, I'll give it a try. I went in there, did a separate interview, kind of told my other leadership roles that I've had in the past, and got told that I was hired for this job. And I think that it's given me such a different, perspective on medicine, just because there's so much that goes into medicine that people who are working with patients clinically don't see. All the billing and coding that, scribes are a big part of, because if we don't include something in the chart, then it can't be billed for appropriately. And we actually just went to a big conference a couple of weeks ago about things like that, where we learned more about the billing and coding aspect of it, which most of the other scribes know nothing about except what we have told them. So I think that the leadership experience has really helped me too. I don't know if I would say that I expected to be like a lead scribe when I first started, but I know that it was kind of always in the back of my mind, like, okay, I might be good at this.
And are you studying up to do something within the medical nursing?
Yes. The initial plan was actually to go to medical school, but I'm actually going back to nursing school now instead.
Did the Scribe program help you to kind of define what?
Yes, because you get so many opportunities to see not just ER physicians, but all types of physicians. We have neurosurgeons that come down, trauma surgeons that come down, and you get to see, how their days operate on a day-to-day basis, whether they're in the ER, in the clinic, or what they have to do. I run the NICU as well right now, so I work up there. So seeing those types of physicians. And then we also, just working in the hospital, you get so much exposure to other things. Like I shadowed a CRNA, which is, I think, my path now that I really want to be. So I think just any type of exposure is really helpful to students, because without this experience, I probably wouldn't have known that.
You'd have probably stayed on the pre-med
Right.
path, not really knowing.
Right.
Sounds like something for your dissertation.
I should think about that. I should really take that under advisement. Good thing you said something. So thank you, Stephanie. Really the innovative aspects to this, there's a lot of things that are slightly innovative, but I think the best part about this is the combination of all of these things together. So really what we're talking about is we have a community and university partnership, specifically with Covenant, to work with them to provide trained physician facilitators for the aspects of the hospital. And of course they provide our students not only with employment opportunities, but with clinical observation during the coursework. So everyone who takes the class goes down to the hospital a couple times during the semester. They shadow our experienced scribes. They see everything that happens there, and they kind of get a feel for what this is all about. Using team-based learning is not terribly innovative, although it's a very effective method. If you're interested in team-based learning, you should go across the whoever Elson is, because he's doing his whole thing on team-based learning. I'll tell a little bit about it. Experiential learning and workplace learning is the parts that I'm going to hit on most. So the idea for this was launched in Dr. Deibel's backyard. I like to tell people over a backyard barbecue, as we're just there hanging out and just kind of talking about crazy things that just might work. The mission for both SVSU and Covenant centers around teaching. Covenant's a teaching hospital. Their physicians are used to teaching students and residents and people like that, so it kind of fit well there. We have received outstanding support here at the university. At the time, we didn't even have a dean. We had an acting assistant dean. Dr. Ballard was here for a year doing that. Dr. Bashand, who was the provost at the time, supported it up front from the get-go. Lots of people here have made this a very big reality. Same thing at Covenant. When we pitched it to the executive team, we weren't really sure how they'd go for it, but they ended up saying it's just a win-win. I mean, they just loved everything about it. It made sense financially, which of course they care about, but it also certainly enhanced their mission of being a teaching facility. So that's what it was. The support was there. We made the commitment. There's been investments on both sides to refine what we do, to enhance what we were able to do in class. And as Stephanie said, probably one of the biggest investments is people like Stephanie and some of our other lead scribes coming to class pretty much every week to mentor and work with the students who are taking it. That means so much to them. In fact, I kind of feel guilty thinking that I'm the one teaching the class, but really they're the ones giving the best feedback and really doing the more specific things, because they're doing this every day. And so it makes sense that they would do that. The feedback that we've received on this has been phenomenal. People think it's cool, but obviously it means something. This is not something you see just any old place, so we're very pleased with it so far. Using team-based learning, the way to do it, I won't go through everything. The good part about it is that it works well. It works as good, if not better, than lectures and things like that. I don't actually teach these guys anything as far as the medical terminology. We have a packet of information that each student gets. They can teach themselves outside of class. The first thing we do every week is we have an individual quiz, and then we have a team quiz, and then there's a discussion. But usually by the end of the team quiz, as they discuss and they debate and they ask each other questions, they've learned the things that they need to do. It's kind of step by step, just empowering them with what they need at that moment for what we're about to do. And they enjoy the process, even if they don't necessarily do well. People enjoy the class because it gets them out of the classroom, it gets them doing something besides just listening, and the research shows that even if they don't do very well, they still enjoy the process better than just sitting and being lectured to. And a lot of medical schools and other graduate professions are using team-based learning, so when they get there, it'll be something that they're familiar with. We have very lively discussions. Sometimes people will be absolutely sure that the answer is C, and someone else is absolutely sure the answer is not C, and then it's like, okay, well, how do we figure this out? Well, I remember reading this. Oh, I remember seeing this. Oh, I remember this. Oh, okay, now we start to come to a conclusion. We give them immediate feedback with these little cards that have the answers covered over with the little scratch-off things like a lottery ticket, and so they really take that very seriously. They will not scratch off until they're very sure. And that's what stimulates them. It kind of forces them to make a choice, and they'll get immediate feedback on if they're right or if they're not. Then after they do this takes about 20 minutes to get done in class. The next innovation is what we do, what we spend most of our time doing, and that is simulation, which is what you just saw Stephanie do. What we'll do is we'll show them usually 2 videos every week over different systems of the body. The one you saw there was part of the HENT, so head, eyes, ears, nose, throat. This next week we're going to do GI, so abdominal pain, people with gallbladder issues and things like that. They simulate doing it and they get feedback on it. We're trying to prepare each student for being able to do this on their own. Now, team-based learning puts people in groups, which is a good place to start. They have a lot of team support. They stay in their groups the whole semester. They have a lot of support from each other. They can say, oh, did you get that? I didn't quite, how do you word this? Or what are you putting for this? At least initially they can do that. So they don't feel like they're totally thrown out, on their own. Eventually, we want them to do it on their own. So what we do is we can scale back the feedback that they get. So eventually they say, okay, well, you can do this, but you can't ask your neighbor for help. Eventually they'll get to that point. And eventually they do it without any feedback from the scribes or myself or anyone until they submit it for a grade. So they actually submit one of these charts that they would write up for a grade on VSpace, and I would grade it and give it back to them. But they are doing exactly what you saw there. They make a history, HPI, review of systems, physical exam, ED course, which is all the medications and procedures that happen after that point. This is also a good thing for Covenant because the residents are the doctors in there, and so it helps them to kind of think through things a little bit. We've got, I think a couple dozen of these videos that we can show. We have more than 2 per week that we can show, so we'll mix them up, and sometimes we'll pull up an old video or get the residents excited about being in a video to show the students there. This is what I was talking about. They get a variety of feedback. So they can get feedback from me. I'm not doing this all day, every day, so there's, I guess, some degree of limitation of what type of feedback I can give them. But they get the best feedback from their experienced scribes. And I can vary it. I can say, okay, do this just with your group, or do this on your own and then share with your group. Or we'll have the scribes circulating as you're doing it, or we'll wait to have them do it later, or not at all. There's a lot of flexibility to how we can do that. And this is kind of the progress. So they start with everyone working on one chart. Eventually they take one section of it and they all kind of combine what they have into a chart. And then eventually each person does it themselves. Any questions, comments so far? Carrie?
I have a question, John. In the simulation, the doctor did a very good job of very methodically and clearly saying exactly what they were doing, exactly what they were hearing. I mean, and the scribe, so it was not easier for the scribe. Is there training of the doctor in terms of how to really explain everything they're doing so the scribe can make sure they get it all? Doctor, maybe you can tell us.
Dr. Deibel can speak to that a little bit.
We did when we first started. We did some training. However, there really isn't any specific training now.
And is the scribe then maybe trained in the real world setting to say, wait, excuse me, doctor, what did you just do, or what did you just hear, or how does that?
It kind of depends on the physician, to be honest. We work with,
It's kind of just grown to a point where they learn to understand each other a little bit.
Yeah. So like we've, kind of learned that some doctors verbalize everything in the room while they're actually examining the patient, just like he did. Some doctors don't say anything while they're doing their whole exam, and they'll come out of the room and then tell you everything. It just kind of depends on their preference. Once you develop relationships with doctors too, like they'll be examining the patient and just look at you like they're in dance line. You don't need to put anything else. So it's just kind of
a lot of nonverbal.
Right. Exactly.
Oh, that's awesome. That's great. Thank you.
So yeah, it really has. And the scribes tell me about, oh, I worked with this doctor and they like it this way, or this doctor will do something different. So they're really trying to keep up with 40 different physicians that they may work with, and a lot of them, there's some similarities between them, but obviously each person's going to be a little bit different in that regard too. So we use experiential learning during the semester, during the training course. They go down to the hospital 4 different times. They can do more than that, and so in fact some of them do a few extras just because they're very serious about honing their skills. They want to show them that they have the skills and abilities to do it. They see the scribes and obviously everyone else in the real setting. So that adds to the authenticity of what we do in class. They see people doing this for real. That way when they're in classroom, they go, oh, okay, yeah, this is what it would be like in the real world. They progressively, so the first shift, they do a scavenger hunt. They're just trying to find, okay, who is this person that's called a huck? Who are these people in blue scrubs versus green scrubs versus red scrubs, and what does that all mean? Where are the blanket warmers, and where can I find them, that kind of stuff. Eventually, they start to do more skills, and by the third and fourth observation, those are really there to allow our lead scribes to see what kind of skills these students have. And what we tell them is, pretend like you're on a job interview, and you have to show them that you can actually do this. And those who, it's pretty clear, most of them that can do it well, can do it by the third and fourth time that they go down. Some of them take a little bit longer, but we definitely tell them to impress whoever they're working with. They get feedback on their skills. Hey, you did a pretty good job with this. You did an HPI, or you did this part of the chart. Usually they're working on a separate laptop, which is just on called a playground environment. They also get feedback on their professional behaviors. Hey, you were a little bit late, or you shouldn't be asking all these questions. You need to focus on what we're doing over here. So they learn by receiving feedback, reflecting, just like we talked about before. So that adds to what we do in the class. By far, as Stephanie mentioned, the biggest place where they learn is when they work. So they get hired, and they're working, and they see hundreds and hundreds and hundreds of patients over the course of the years. Typically, when you're working with physicians, they're seeing anywhere between, 15 to 20 patients, sometimes more. That's every shift. So they work at least 2 shifts every week. Multiply that by however many years, in this case for Stephanie. We're talking many, many, many patients that she's seen. And also being an active member. This is a very important part. It'd be one thing to say as a pre-med student, I'm going to go watch. And you sit in a corner of the room, and you don't say anything, and you just kind of watch everything. It could be a pretty good thing if you've never done that before. But having an active role, there's research that shows that that goes far beyond, it enhances the learning far beyond whatever you'd get just by passively watching. And students are lucky to get the passive thing. They're lucky to just be able to watch a real doctor seeing real patients. So this is a big thing. Yes?
What percentage of the students who take the class end up working for employment in the hospital?
Varies from class to class. I would say somewhere between 40 to 70%, and the classes are usually between 15 and 20 students.
Do you know if there's any difference between the students who choose not to versus students who do? Is there a big profession?
Some of that, yes. Some of that is because they already have a clear professional intention that does not involve medicine, so it may not be in their best interest to do this. Others, they somehow realize that maybe I'm just not cut out for it. Some of them realize I don't want to be in an emergency room setting because it's way too gruesome in there, or they don't like the nights and weekends thing, for whatever reason. So there's some career exploration that comes prior to, making even this decision, much less am I going to apply to medical school or some other thing. So yeah, the students for the most part take themselves out. Most people who apply for a job have gotten a job. Those that want to do it are able to do it.
I mean, that's really okay.
I think it is. I think it's really cool that just this experience alone has a big impact on people's professional goals. Some people are kind of debating between two, and they come away with saying, I know exactly what I want to do. Or sometimes people who are so set on one thing go, now I'm not so sure because there's all these other things. It's exactly what we want.
Well, the student said this is not for me.
Yes. Yes, absolutely.
Really cool. That's really
Absolutely. No, we're happy with all of those things that happen. And some of it happens because during the course, sometimes it happens after they've worked for a while, and I'll share an example of that. They become an expert with the most used electronic medical record in America. Epic has a big chunk of the market share as far as how frequently it's used. So anywhere they go, there's about a 50-50 chance they'll be using Epic. And they're already, in fact, these guys are probably the experts in the emergency department. They're showing the doctors how to do stuff with it that only a few of them may know how to do. A lot of the learning is applicable down the road, meaning it's not necessarily for what they're doing here, although they do see applications of anatomy, chemistry. Why do we have to add sodium to this IV? Oh, because of this. Oh, saw the person's leg sticking out. Oh, that's the femur. Or, things like that. They're definitely motivated. That's kind of my thing. So they're definitely motivated to just go, oh yeah, this organic chemistry is making sense, or this anatomy class I'm having, I've seen things along this line. So these are just things that I hear. And so one of the things we're going to do as far as research goes is to find out exactly, maybe a little bit more about what applications are they seeing and what does that mean for them as they go along. Also, they learn a lot of things that aren't taught in class: ethics, professional behaviors, legal liability type of things, the business side of healthcare. They don't really get, especially pre-meds, don't get any of that. They're too busy taking science classes. So they learn from experience a lot of the things that really you can have a class on, but it's so much more effective just be there doing it. So really the impact, I want to talk about the students, Covenant, and SVSU. So I've invited both Stephanie and Dr. Deibel to talk about their respective areas. Here's some of our students who've taken the course, who've worked as scribes for one period or another. Stephanie, you've talked a little bit about it. What more can you tell them about your experiences?
Well, I kind of have already talked about that it kind of swayed me in a different path other than becoming a physician. But I think other than that, just getting like that hands-on experience, you know, walking into a trauma and being like, wow, this kind of stuff really happens. Like some of our students who come on observations, they'll come in with us and we always like give them passing out precautions because you don't know if they can handle that. So, you know, I think that has really helped me because I've seen a lot of things that I never thought I would have seen at my age. And I think that's really helped me learn how to cope with certain things and know that, yes, I can, you know, keep going in my career and keep going in the health field and things like that because I can handle it. Like he was saying, a lot of people get there and they're like, I do not want to do this. The one on the left up there, Riley.
Riley, yeah, she's the one I was going to talk about.
Yep.
Go ahead.
So she planned on going to medical school.
She was in our second class that we ever did back 4 years ago. So she was working as a scribe for a good 3 years probably.
I think her first year, she's like, you know, I do not want to be a physician anymore. And now she is in an ecology program up at Michigan Tech.
So her classes are hiking around with trees and rabbits and stuff. It's great.
Right.
Steve Spatafor, not one of our students. He graduated from U of M and graduated from down there and then came up here and took the scribe class after being done. He's from this area. His father's one of the physicians in the ER. And Steve worked there for a while and is now, in fact, Steve, Stephanie, Randall, these three are currently in medical school, CMU, Michigan State. Christina is in a graduate level health psychology program out in Arizona, loving it, has said many times that being a scribe was the best thing she ever did here at SVSU, better than any class she ever took. When they went through all the psych drugs, she was like, oh yeah, I know all about them. I've seen people on them, seen people who needed them, all those kind of things. Amanda is one of our other lead scribes. She's been a lead scribe for a long time. She just started our nursing program. And there's one more person I didn't put on here, Jessica. She works in the NICU. She found her calling in life. She was set on going to medical school, and she got to work in the NICU, and she's like, I just love those little tiny babies. So her calling in life is to cuddle the NICU babies, and she's going to be a NICU nurse. So she's absolutely loving it, has found really what her passion is. So all this stuff is exactly, kind of, whether it's shaking things up or reinforcing what people want to do, it's exactly what we had hoped for.
Stephanie, do you get to the point where, I know you said you work with multiple physicians and stuff like that, but do you develop enough of a relationship with certain, docs or nurses that you feel comfortable going to them for a reference for if you went on to graduate nursing school or if you would have gone to medical school?
So I would say that that's probably my favorite part. I have such personal relationships with so many of the doctors, like coming in, asking them how their children are doing or how so-and-so did at school today, things like that. It's really cool because a lot of people think, oh, doctors, they're so smart, they don't really talk to people. Like, when I walk in and work with the doctor, they're like, yes, I have a scribe today. Like, they're just so happy to see you, ask you how you're doing, and, they talk to you as a peer, not as your superior, which is really cool because a lot of pre-med students don't get that interaction. And I have asked multiple physicians for letters of reference, and they have been more than willing to write them for me. So it's really awesome.
And the other stuff too, Stephanie, I mean, obviously the knowledge you have of the field is good, but just in conversation, I'm sensing maybe developing leadership skills and everything. I can imagine, interviewing you for a job right now and thinking, wow. Right? That's the sense I'm getting from this.
Maturity that kind of comes with it.
You should see the stuff that these guys have to keep straight, how many different schedules and how many different color coding things go on. It is insane how much these guys do. But they do it very well. And they are on top of things, and they are providing a great service to the people they work with, but developing along the way.
Yeah, I think I've definitely matured a lot since I started working at the hospital. Not just as a lead scribe, but as a scribe in general, and working with people that are a lot older than me and physicians, and kind of just growing up like that.
So here's some of the things that I think are going on with students, just based on what they've told me. And we've talked a lot of, obviously, early exposure to the field of medicine and everything it entails, which is hard to get. There are a lot of barriers for people getting in to see. Like, it's documented that pre-med students want to get in, they want to shadow people, but they're not able to. So being able to have any kind of exposure with real doctors in a real setting is awesome. Training for important concepts in healthcare. They earn money, they get paid fairly well, especially considering they can get paid after a one-semester training course. Career exploration we've talked about. To associate with professionals, to me this would be one of the coolest things if I put myself in that situation, is they're literally just joking around with these professionals that are saying, yeah, I want to be like these people. And they really do develop true friendships. It goes so far beyond you're this and I'm that. I mean, and this is a very unique setting for them to be able to have those relationships. So now I'm going to ask, we won't go through all the slides just in the interest of time, but if you just want to talk about, from your perspective, some of the things that you've seen from the hospital and for your own perspective as a physician working there.
Sure. So Stephanie kind of said it. When a doc comes in, we don't have quite enough scribes to cover every single shift, and so you come in and you're like, my name is Scribe Advantages. And you feel like, oh yes, you're working with me today. That's pretty much routinely the response that you get from pretty much all the physicians. This is, let's see, it's been interesting watching this kind of progress over the years. When it first started, and John and I were kind of doing that first class, it was definitely...
We made it up so hard.
We made up everything.
Week to week, what do we want to do this week? Oh, this might be good.
And the first scribes we started with, too, some of them were really good, some of them not very good. And realizing, for me, I mean, the students are still in college. They're not very far out of high school, and there's definitely a maturity that sometimes has occurred and sometimes has not occurred. And so a lot of this has gone through, and it's been fascinating watching it now, these scribes that we bring on after they've gone through this class, the level of maturity, the ability of them to put these notes together far surpasses what we were able to do with the first group. So that's been really nice to see. And a lot of that is because of this key where the lead scribes come back and help teach the class. They bring back some of those key aspects with them when they go back and teach.
There's been a lot of continuous improvement with the lead scribes working with the scribes that are working there, as well as trying to intervene with the class that's being taught so that we avoid making some pitfalls and take advantage of some opportunities. It's been definitely an ongoing process. I meet with them usually a couple times a year. What are we going to do? What are we going to change? How should we be doing things? Now we're doing some things where they're actually looking on the chart, seeing how a CBC actually comes back, which is just a bunch of numbers and little abbreviations, and trying to make sense out of that jumbled mess, which is a big part of healthcare as well. But now we're doing it in the class so that they're that much better when they actually get hired.
And when the lead scribes in particular, all of our scribes are really good, impressively good. But our lead scribes are the best scribes that we have, and the leadership abilities that they both come with and they develop while they're in that role is amazing to me. And that's been just a really neat thing to watch. So, as far as the class and watching these scribes come through, for us, it's been wonderful. For me, it makes all the difference in my shift, because if I don't have a scribe, I'm doing my notes as I go. It's more stressful. Every patient, I should be doing my charting as I go, so I'll sit down, and it's a little later that I see the next patient because I'm trying to get the charting done for the first patient. At the end of the day, then maybe I didn't keep up with everyone, and maybe I saw 20 patients that day, and it's just you have this pile of paperwork that you need to go through still and sort and sift through everything. it's much more stressful. If I have a scribe with me, I go in the room, I don't even think about taking notes, I just sit down, face to face, have a conversation. Patients really like it also, because I'm not going, the whole time. Instead, well, tell me more about that, and then the scribes in the back are just kind of frantic, and I'm like, I don't know how that's too bad sometimes. But they capture all the key stuff. And the other thing is, I will be in there for 10 minutes having a conversation, and it'll drift in and out of important topics and not important topics. And they're able to figure out, tune out the things that are not important and tune in the things that are important and make it sound like a note that is well written. It's interesting talking with our HIM, health management records, our records people and coders and builders and all of them. They say the Scribe charts are some of the very best charts that they see. And I would say in general, a Scribe chart is as good as you have residency, so first, second, and third year residents. An average Scribe chart is as good as probably an advanced second year resident who's already gone through 4 years of medical school, which is pretty impressive. Wow. So, and some of the best Scribes notes tend to even be better than most third years notes, pretty much most docs too. So they kind of figured out, they put it in a nice cohesive manner that's easy to read. What I also like about this class is there's places, Scribes is not a new concept. Having it paired with the university is, as far as we know, this is the first in the nation that's done this. And it really is a win-win on both sides. In some places, I know we had talked with the University of Virginia as we were kind of developing some of this, and they had something, and they had a lot of pre-med students there. Anyway, they would get 10 applications for every one person they took into their class. And so the other 9 out of 10 never had a chance to even try to learn about it, because once you were hired, that's when the training started. So they never had a chance to observe, they never had a chance to shadow, they never had a chance to do any of those things. Whereas with the class, as long as you do the prerequisites, anybody has a chance to be able to jump in and see, is this right for me, or is this not right for me? Which I think is a pretty neat opportunity.
So as Matt said, it's a big burden lifted off the physicians by not having to do the documentation, and it frees them up to see more patients or to spend time thinking and making those critical decisions for their patients, which is really what they're there to do. Just fast forward through this. The physician verbalizes the physical exam. That happens more or less. You get some of it maybe outside of the room, but they get more face-to-face time.
The patients love that. You're in there, oh, your lung sounds clear. Oh, heart sounds regular. Of course, I'm saying it's so they can put it in the chart, right, but the patients just eat that stuff up.
I would think so.
And as a physician, you forget that if you're not, you forget to say something oftentimes. You're in the room and you examine them, in your mind, it's done normal. And the patient never knows it's normal. All they know is, what did he think? Is he worried about something? Or
exactly.
There's been a really good acceptance rate, and even with very private, confidential, personal things that patients come in for, something they wouldn't want to talk about with their, anyone else, they have generally no problem having a scribe in the room because, again, the physician pays more attention to them, and they have no problem talking very openly about what's going on. There's other research that suggests that that's the case in just about everywhere where they have scribes. So they're not limited by that kind of stuff.
Doing this for about 3 or 4 years now, I've only had one time where they asked the scribe to step out of the room. And it was the very first day I was doing this. Which is not a good omen. That was the only time it happened, was the very first shift. Have you been asked to step out of the room?
No, I've never been asked to step out.
Yeah, and these are pretty personal things. You can, yes, it's it. Yeah.
You've been able to recruit some people because of Scribes?
We have, actually. We have a couple docs here, like Scribes who'd be interested in coming here. People that, I would never work at a place without Scribes again.
Especially those who have worked with them before, oh my gosh, that's a big, big deal for them. Patient flow, we're looking to see if these results are true for here at Covenant, to see if we can help slower physicians become more efficient, more productive, see more patients per hour, that kind of thing. They can help monitor for things called core measure, which is kind of the things that they should do, but kind of best practices in medical care. For example, someone coming with a suspected heart attack, you give them aspirin, those kind of things. They can document. They're doing it, but sometimes it doesn't get documented, so we're making sure with the Scribes that they can actually get that documented. The physicians were kind of cautiously optimistic at first. They thought, well, this could be good, but they're kind of a wait and see. And almost universally, they love working with Scribes. There's only a few that don't work with Scribes, and that's a lot of them. It's just because the way they go about approaching patient care, they just feel like it would be better off for them to just work by themselves. They're not necessarily fundamentally opposed to it, but they just work better, they see it better on their own.
And for example, with slower physicians, we did have one physician that was not doing the charts frequently enough that it was going to become a real issue, like even keeping him employed. And so he always has a scribe, and he has no issues now, which is really good. Yeah.
Obviously, with the scribes, Dr. Deibel told stories about when he was going into medical school and thinking about being a physician, trying to just get anything on a Friday night. Anything in the hospital was a good thing, but this is obviously something that's much bigger than that. We worked with the University of Virginia, as Matt mentioned, and they boasted 90% acceptance to medical school from their scribe population. So we're hoping to see something like that. The community advantage, obviously with CMU's medical school now here, the residency programs are still there, medical students. A lot of them have talked about returning back here as either residents or attending physicians. So like, hey, I love all the people I worked with, I had a good experience there. They think they may actually come back here rather than just going for wherever else they could go. And obviously Covenant's mission of supporting education aligns very well with our own. So lastly, just to talk about the impact here, obviously this is a unique program. It's one of the few university-based, it's not the only one now. There's been a few others that have come up since then. They only had a public university in Michigan, and it gives our students an advantage. It's something that not everyone can say. Even the Michigans and Michigan States of the world can't offer the same exact kind of thing to their students. And I get students who are there, who are from here, and they are asking about, hey, can my child do this, or can I do this sometime? And so it's been a thing that we can use to recruit and retain students. Our mission, create opportunities for individuals to achieve intellectual and personal development, which is exactly what we're doing. They're growing intellectually, growing personally. Stephanie talked about growing up a little bit, just because the nature of the position facilitates that. And professionally. I mean, these students really have an idea of what it means to be a professional within the healthcare field. This is a screenshot. I have the unfortunate duty of having to go present this in Tampa in a few weeks. Using team-based learning and simulation is a little bit of a unique combination. So I'll be presenting this at a team-based learning conference in Tampa over spring break. Screenshot from one of our videos there. This is a unique thing, and obviously the context in which we do it is a little bit unique as well. Lots of other scholarship opportunities. Gary, you mentioned my dissertation. It's on its way. I'm going to study those who are in medical school to find out, now that they're in medical school, what things do they look back on from their medical scribe experiences that mean something to them. We think we know. We think it could be any number of things, but we don't actually know what they think is the most important. So there's absolutely no research on medical scribes in this educational context out there. So this, I'm hoping to be the first of its kind. Also some collaborative research with Covenant. We're looking at productivity, efficiency of ED physicians. We're doing some stuff with the residency program. They did a study on, can you teach better when you have a scribe? Can you relate more with the resident when you have a scribe because you don't have to worry about as much documentation? And Carrie, you and I need to still work on that narrative.
Yes, we do.
Getting that out there. So
we're going to do that, John.
Lots of potential things there. And obviously, the community impact. We care deeply about this community. That's the mission of this university as well. So we strengthen our relationship with a community partner. This was part of the Carnegie Community Engagement process. I know this was part of the application that was submitted there. We were able to get that. Patients go to Covenant and they see SVSU students. Oh, hey, who are you? What do you do? Oh, I'm at SVSU. I'm studying to be a doctor. Oh my gosh, that's really cool. Local employment, gain experience in medicine while in school, strengthens the local economy. Healthcare providers and hospitals kind of find a good match. So people who've been here, they're like, I love my time at Covenant. I may want to go back there. And they do want to come back because, of course, especially as physicians, they know they have scribes. So having been a scribe, they're probably more likely to say, I'm probably going to want a scribe for my practice. So that's all I got. Any questions or comments?
John, do you guys have any data on, from the students that have gone through the Scribe program, what their acceptance rate is into any type of post, any type of graduate school, it's med school, PA school, graduate school?
I track those a little bit, just kind of informally. Haven't run the numbers as far as like percentages and things like that. The issue is because we have so much career, decisions that change. Some people, and people do this at different times of their career. Some people are doing it as seniors right before they apply. Some of them do it as sophomores. They work for a few years. But we know who gets accepted to medical school. We know who decides to do something like nursing. We have people who do an accelerated nursing program outside of this area that go for a year and a half. And once they've graduated, things like that. Haven't run the data formally, but we have that information that we could look at.
I assume it would be probably pretty high, given that everything they're being exposed to, you know, at the undergraduate.
Yeah, it is. The unfortunate thing is that a lot of really bright, talented students may be limited, for example, going for a career as a physician. MCAT and GPAs are still the biggest things, and it really bothers me because those are the things that weed out so many other people, and yet we've got people who've been doing this for years who would make great physicians that, for whatever reason, can't break through that. That to this day just really bothers me, that we've got really great people that can't get through that.
And the ones who go for interviews that get accepted, from the feedback we hear, a lot of their interview ends up being talking about their Scribe experiences and things like that, and then they get accepted. And
we've got a few students where that's all they talk about, and we're pretty sure that's what got them into the
So for those that do pass the MCAT or get a high enough score or whatever
the interview phase, it tends to be very helpful.
Because they know that they don't have to teach. This is not a raw piece of clay they're going to have to shape in every direction. They've already been shaped and molded and have all this wealth of experience to draw on. So they know they don't have to teach them all those things. So they're obviously inclined to want to take people like that in their program.
It would be really interesting to see, this is a huge research project, but sort of what you're looking at from the hospital's perspective, how this is improving efficiency, maybe improving care, what the move, you know, with Obamacare and all that's come down on, you know, accountable care organizations and really paying for performance, and the best hospitals are going to get, you know, paid, and I mean, that's our world now, and how medical scribes really could maybe help to affect performance of the hospital, you know, and so maybe that really becomes a very important part of the equation.
Because really be from a patient care and an economic standpoint for the hospital.
We've already kind of seen that a little bit as it relates to just the documentation. Like you said, the Scribes charts are capturing little things that may not have been entered or entered the right way. So obviously a lot of that stuff is going to relate to the documentation that gets done.
Yeah.
So there's a very good case to be made for that.
Yep. Very awesome.
Yes. Any other questions? Ted, you and I were talking, I think, about people that have taken this class. Some people just do it for the upper level credits.
Sure.
So people who are doing, perhaps they're in healthcare, loosely defined as one of the many programs in our college, or maybe still thinking about doing it. So they take this class, they get 3 upper level credits for it, and they get a chance to go down. Some of them start their observation, you know, with this. Others, it's like, no, I've been doing this and I'm very serious about it, and this is a continuation of it. But yeah, for any number of reasons, I think it's good that we have it as a university course for students to be able to add. It's not required for any program, any major, but it does provide some things that students want, like 3 credits, upper level, minimal prereqs, stuff that they would have already taken for most of them. So. Okay, thank you for coming. Thank you for being here.
Grassroots project. I mean, it's really coming from a backyard.
Yeah, backyard barbecue.
It is the quintessential sort of community engagement, working with a partner to develop a program.
It's been fun. We've learned a whole lot of stuff. We presented this to get it approved in different levels. You know, we kind of agreed this is a good idea, but then you got to convince everybody else it's a good idea.
Yeah.
The narrative that could be written here could truly be a narrative. One day, backyard.
Well, we've talked about that.
Absolutely.
The non-peer-reviewed journal kind of like that.
But we figured, how many students have we had so far? 60, 80?
Yeah, between 60 and 80, including the current class that we have.
We've had about 40 people that have come through and looked at Scribes, roughly, I don't know, 50, somewhere in that area. So it's affected a lot of people to have a chance to do this.
Well, thank you.
And you said we're the only of the Michigan Public John that
Correct. Kettering University kind of